Excellent. And so yes, the topic that Dr. Taylor and the organizing committee gave me today is chronic kidney disease mineral bone disorder, abbreviated CKD-MBD, which initially I thought was going to be super easy to do. But as I was putting together these slides, I kind of changed my mind. To be frank, we don't treat mineral bone disorder very well in our patients. Most of the drugs that we do give don't help our patients live longer or live better lives, and I'll talk about some of that evidence. But at the same time, well, actually, because because these drugs, the evidence is so poor, I think a lot of clinicians have become indifferent when it comes to treating or how they treat mineral bone disorder. But when you give everybody the option of whether they would treat it or not, I think most people would say that they would still treat it. And we do treat it, and we spend a significant amount of resources treating it in the province. We spend several $1 million on drugs and human resources and laboratory tests. So the goal today is to just make sure everybody in this room is comfortable with mineral bone disorder and what exactly we're trying to achieve when we treat it. So you can Google, if you find these slides useful, you can Google it after. It's available 24/7 online. And as a pharmacist, of course, we're going to talk about the drug treatment of mineral bone disorder. But also what we're going to do to try and keep you engaged is to tackle some of these controversies head on. I'm going to tell you what I think about some of these controversies and what I would do. And if you disagree, after, just come up to the microphone and we can discuss it. So I do have a bit of an ambitious agenda and only 30 minutes to talk to you guys about this. We're going to start from the very beginning for some of the students here. We're going to define what mineral bone disorder is, and then we're going to go all the way to the latest clinical trials that have been published just a few weeks ago. So let's get started. So just to be clear, mineral bone disorder is not just a condition that affects bones. It's a systemic disorder manifested by one or a combination of the following: abnormalities in calcium, phosphate, parathyroid hormone, or vitamin D metabolism, abnormalities in bone, mineralization, growth, or strength, and lastly, abnormalities or vascular calcifications or soft tissue calcifications. And as you can all appreciate, these are all surrogate markers for what we do think is happening in our patients with mineral bone disorder, which is an increased risk of fractures and early death. And what's causing this increased risk of mortality, again, is not so much the weakened bones that happen, but one of the factors is the extraskeletal calcifications. And so depending on what literature you look at, 50 to 90% of our dialysis patients have vascular calcification. And what you'll see in a lot of studies is looking at aortic stiffness. And so if you have a really calcified artery that your heart is pumping against, that increased pressure is thought to cause or lead to hypertrophy, and left ventricular hypertrophy is associated with sudden cardiac death. You could have calcification of the arteries that bring blood to your heart, which is thought to contribute to the increase in cardiovascular mortality we see in our patients. And lastly, you can have calcifications in the very small arteries, which leads to ischemia and subcutaneous necrosis, which we also call calciphylaxis. To summarize, really, we can have calcifications anywhere in the body. And so when we talk about some of these endpoints, when we talk about drug treatments, you'll see aortic calcification, coronary artery calcification, calciphylaxis, mortality, and fractures being mentioned over and over again. So what exactly is mineral bone disorder? How exactly is it happening? So it happens quite early when the GFR falls to just below 60. And there it is. I'm going to have a diagram here. So let's start with the kidneys. The GFR is declining. Traditionally, we're taught that phosphate starts to rise, but if all of you have seen patients with the GFR just under 60 and you don't see high phosphate levels, you rarely would ever see that. What's really thought to happen first is a decrease in activation of vitamin D. That's due to decreased activity of 1-alpha hydroxylase. When you have a decreased vitamin D, you have decreased absorption of calcium and phosphate from the small intestines. That leads to decreased levels in calcium in the blood. Then your parathyroid senses that and releases parathyroid hormone. And of course, parathyroid hormone stimulates the osteoclast in the bone to break down bone, to bring calcium out, to start to normalize that calcium. And all of that is also propagated by that decreased active vitamin D, which causes less suppression of PTH. So parathyroid hormone doesn't just act on bone, it's a signal to the kidneys as well to excrete more phosphate, to conserve more calcium, and to activate more vitamin D. But as the kidney mass continues to decline, when you start to hit CKD 4 and 5, eventually you will see that high phosphate level. And that high phosphate level chelates, or high phosphate chelates with calcium. That can deposit into things like into the vasculature and cause calcifications. It's not quite that simple. High phosphate levels and high PTH levels, just having that high level is thought to cause smooth muscle cells in the vasculature to become osteoblast cells or bone-producing cells. And lastly, to complete things, FGF23 goes up when phosphate goes up, and that decreases activation of vitamin D. So just to summarize, you first have a decrease in active vitamin D levels, leads to a decrease in calcium levels, both cause an increase in parathyroid hormone, and eventually you get an increase in phosphate. So what are the goals in terms of treating? Well, because you have that breakdown in bone to help normalize the calcium levels, you want to prevent weakened bones. You also want to prevent the calcifications that we talked about. Next goal of treatment is also to prevent parathyroidectomy. If you're constantly producing parathyroid hormone, then the gland hypertrophies and you may have to surgically remove it. And you do all of this by controlling or keeping calcium, phosphate, and parathyroid hormones within targets. Now, this is the targets recommended by KDIGO back in 2009. These are the latest guidelines. You can see calcium phosphate towards the normal range, PTH in a PD patient, 2 to 9 times the upper limit of normal. And this where we'll begin our first controversy. So a lot of people look at these targets, and the truth is there is no studies that examine the benefits of targeting different calcium, phosphate, or parathyroid hormone levels. And so what is the theory behind this? Well, in terms of calcium and phosphate, if you believe in years of evolution, the calcium and phosphate levels that are naturally found in our bodies, the perfect balance to keep cellular function normal and to keep bones healthy. So therefore, we target the normal range. Parathyroid hormone is a little less straightforward. This 2 to 9 times the upper limit of normal was actually based on just one study. This was published in KI in 2006, and what they had found was that when parathyroid hormone levels were at the extremes, or 2 to 9 times the upper limit of normal, that's when mortality was the highest. Now, subsequent studies have looked at bone pathology when you have PTH levels between 2 to 9 times the upper limit of normal, and it does not correlate very well. So PTH levels are based strictly on this data on mortality. What makes this a little bit more complex is that not all studies consistently show high PTH as being linked to increased mortality. And this is an example. This is a systematic review published in 2011, which found no correlation with high PTH and mortality. But it remains that in our PD patients, we target PTH of 2 to 9 times the upper limit of normal. So that mortality is not quite known, but when it comes to phosphate, it's consistent in all studies that an increased phosphate has been associated with increased mortality. Now, this, again, is a systematic review, and it found that for every 0.3 millimole increase in phosphate above the normal range, you get an 18% increase in mortality. And for every 0.3 millimole increase, you get a 10% increase in cardiovascular mortality. And so when it comes to treating mineral bone disorder, based on this data, it's usually what the focus on is first is reducing phosphate levels. So phosphate's an interesting ion. I thought we'll spend a little bit of time on it. The molecular weight is actually quite small, so it's actually smaller than serum creatinine, but despite this, it doesn't get removed by dialysis very well. And the reason for this is that phosphate, 80 to 90% of it is found in bone, and therefore if it's in the bone, you can't remove it by dialysis. The other 20%, or 10 to 20%, most of that is actually inside cells. Only about 1% is found in the blood. And so, for example, if you give a 4-hour hemodialysis session, you can very efficiently remove that 1% of phosphate that's in the blood, but 99% of it is still within cells or in the bone, and eventually the amount of total body phosphate you've removed is very little. What complicates it, so those are factors that reduce removal by PDN, HD, and what makes it even more complicated for PD is that phosphate is bound to protein, and that phosphate is negatively charged. So if it's negatively charged, it makes it very difficult to move between capillary walls or interstitial matrix to get into the dialysate fluid. So phosphate elimination isn't well studied, but I thought I would show you this pretty interesting data that gives you an estimate of how much phosphate is actually removed by peritoneal dialysis. And you see CAPD and APD at the very bottom there. Per week, phosphate removal per week, you probably get just under 3,000 milligrams, and compare that to hemodialysis above. So the problem is the weekly burden in North American diet is about 1,000 milligrams a day. You absorb about 70% of that. So at the end of the week, you've probably taken in about 5,000 milligrams of phosphate, and you've only removed less than 3,000 with dialysate. So you're in a positive balance of phosphate. So the first thing we tell patients to do is to restrict phosphate. This recommendation is back in 2003 from Kidoki to limit intake to 800 to 1,000 milligrams a day. And that was completely opinion-based and actually very hard, in my opinion, to do. If I had to follow this phosphate diet, I would be horrible at it. So some examples are having a popsicle instead of ice cream, which I would find completely hard. Maybe a nice glass of herbal tea instead of your hot chocolate. So really, I think patients find this quite difficult. And when you look at this opinion-based recommendation, what exactly are we doing? So this is the first study that I'm going to talk about. This was a post hoc analysis published in 2011 of the HEMO study. And the HEMO study was basically looking at different outcomes from different dialysis prescriptions, specifically hemodialysis prescriptions. And by doing that, they really strictly controlled how much phosphate was being taken in by patients. And so this post hoc analysis looked at patients who had severe phosphate restriction, confirmed by dietary intake by the dietitians, compared to a whole bunch of other intakes of phosphate or different levels of phosphate intake. And what was surprising was that found when you compared really strict phosphate intake to no phosphate intake, you actually reduced your risk of dying by about 29%. So there's a lot of limitations with that data because it was retrospective observational. There's a lot of confounders that could exist. They didn't look at phosphate binder usage, but I think it teaches us a few things. So not all phosphate-containing binders are equal. So phosphate-containing foods are equal. So I think we should be careful on how we educate our patients. I think if you give them that daily intake of 800 a day and they're then taking in a Diet Coke and a Pepsi and some ice cream, they're happy that they're below. I think that is not the way we want our patients to think. It's the quality that's important. Because the severe restriction could actually lead to unintended reductions, and everybody has different requirements in terms of intake, and so I really trust our dietitians to give our patients an individualized plan. So let's talk about something I know more about as a pharmacist, is the drugs. And when it comes to phosphate-based binders, well, there's two. There's the calcium carbonate and calcium acetate. Now, I'm not going to go through everything in this table. I've included in here in case you need it, you can refer to it as a reference later on, anytime you want on the internet. But the point I want to make here is that calcium carbonate is the cheapest calcium. I'll tell you the prices of all these different products after. It has more calcium per tablet, and it's more efficient per milligram of calcium as a binder compared to calcium acetate. And some people feel that calcium acetate gives more GI upset. There's also non-calcium-based binders. The three that we have on market here in Canada is sevelamer, hydrochloride and carbonate, and also lanthanum. And again, I won't go through everything in the table. These products are restricted in British Columbia, and I'll tell you why that is. But to quickly mention that sevelamer is a non-absorbable polymer which exchanges phosphate for chloride or carbonate. So if you're exchanging for chloride, your risk of acidosis is increased. Lanthanum is a heavy metal. You can find it on the periodic table. You can also find it in things like car batteries, but it happens to be a very good phosphate binder. And we'll talk about it. So these new products have come out, and the controversy here is that there's a lot of data that's coming out that's saying, too much use of calcium is a bad thing. That's causing mortality in our patients, specifically cardiovascular-related mortality. We should use more of these more expensive agents. Let's talk about that. So the first meta-analysis was published in 2011 by Cochrane, looking at adult patients, CKD stage 3 to 5D, specifically including RCTs and quasi-RCT data, comparing calcium salts, lanthanum, sevelamer, and importantly, placebo. And the outcomes they found in this Cochrane review, the first two I want to mention, they certainly found less hypercalcemia with the non-calcium-based binders. They found sevelamer had more GI adverse events compared to all the other binders. But the main outcome that they were looking for was mortality. And no matter what the combination was, whether it was sevelamer versus placebo, sevelamer versus calcium salts, lanthanum versus placebo, lanthanum versus calcium, calcium versus placebo, acetate versus carbonate, it really did not matter. No matter which product you chose, there was no difference in mortality. And that was again published in 2011. But then 2 years later in Lancet, the group out of Alberta published this meta-analysis, as I'm sure most of you are familiar with. They were looking at, again, the same population, but they included non-randomized studies and extended the systematic review to 2012 from 2010, looking at calcium-based versus non-calcium-based binders. And what they had found was that if you use a non-calcium-based binder, you reduce your chance of dying from any cause by 22%. When you look at the meta-analysis data, the data is only as good as the data going in. So that's why what we did was we looked up the original studies that were included in the systematic review and the meta-analysis. 7 of the 9 studies showed that there was no difference in mortality. There was 2 studies that drove the results that we found in the meta-analysis. The first one was an observational study, a retrospective observational 2-year study done in Veterans Affairs patients, and they found that sevelamer caused reduced mortality compared to calcium carbonate, about a 23% reduction, 33% reduction. Again, just observational data, so hypothesis generating, not definitive. The second study, the main study that contributed to the decrease in mortality data was BRIC. And this is a prospective open-label study in 101 hemodialysis patients that were on dialysis already for 3 years. They then took those patients who were on dialysis for 3 years, randomized them to calcium acetate or sevelamer, and followed them for 1 year looking at coronary artery calcification. They were not looking at mortality. In that 1 year time period, they found that they happened to observe 8 additional deaths, or 8 deaths in the calcium group versus 1 death in the sevelamer group, which was statistically significant. But if you look at the study themselves, it was not meant to look at this. And so even the authors themselves say that this protocol was not designed to look at mortality, and therefore interpretation of this information could be misleading. But again, these are the 2 studies that caused this meta-analysis to come to the conclusion that non-calcium-based binders cause reduction in mortality. And so most clinicians, after seeing this study published, were pretty skeptical of these results and continued to use calcium first. And that was it just until about a few weeks ago, just at the end of February actually. Another systematic review was published. Adults, same population, looking at RCT and quasi-randomized trials, comparing calcium salts specifically only to sevelamer, not to lanthanum. And again, found that sevelamer had lower all-cause mortality. In fact, a pretty dramatic reduction in mortality, at 46% reduction in risk. When you look at the data again, 7 out of 9 studies actually found no difference in mortality. They included BRIC, as I just mentioned, which had its limitations, but also included a new study that was published in 2013 called Independent. Now, in Independent, they're looking at new incident HD patients with open-label RCT for 24 months, looking at calcium carbonate versus sevelamer. They found a huge reduction in cardiovascular mortality with sevelamer, over 90% reduction if you use sevelamer versus calcium carbonate, which frankly is inconsistent with everything else that's published in the literature. There's some other limitations there. The calcium group had higher baseline coronary artery calcification, and also the calcium group had poor phosphate control throughout the study. And this is probably, or may have contributed by the open label design. So at this point in time, if you believe some of that data, which is quite poor, the evidence to use sevelamer is really quite underwhelming. At least that's my take on it. That's still better than lanthanum, where there are no RCTs that I'm aware of examining mortality or cardiovascular disease outcomes. So when it comes down to it, is it worth that extra cost? No. The way I've had set up this table is you can see the price for equivalent phosphate binding doses. So calcium carbonate, 500 milligrams is 3 cents. Sevelamer, 800 milligrams is about $2 a pill. Lanthanum, 250 milligrams is just over $1 a pill. So is it worth the extra cost for very questionable benefits? This is the best data that we have to date. It's a few years old now. This is done by Braden Mans in Calgary. And they did a cost-effectiveness analysis, and they found that it was not cost-effective to use these products, sevelamer and lanthanum. And there's more data to support that in the Canadian setting. And so really, in British Columbia, calcium binders remain first, but patients who do need sevelamer or lanthanum, as determined by their team, do get it covered. But really, it shouldn't be for everybody. The data is just not there. We'll move on to vitamin D analogs. There's only 2 on the market in Canada. That's alpha-calcidol and calcitriol. Alpha-calcidol costs 50 cents a tablet or capsule. Calcitriol costs about $1 a capsule, so alpha-calcidol is half the cost. There is no data comparing the 2 products. So really, there should be no advantage between the 2 that we're aware of. You'll probably see alpha-calcidol being used more in your units because it costs half the amount. What is the difference between the 2? Not much, other than alpha-calcidol does need to be activated by the liver first, whereas calcitriol is the active form. The controversy, or the question that I get a lot as a pharmacist, is why do we use intermittent dose versus daily dose? So we often see alpha-calcidol or calcitriol 3 times a week versus instead of giving it every day. And the theory here, the thing is, I just want to make clear, these vitamin D products do not get removed by dialysis. That's not the reason why we're scheduling it after dialysis 3 times a week. The theory here is that you get similar or maybe better PTH control with lower calcium and phosphate absorption. So if you have less vitamin D around, which has a very short half-life, therefore you'll absorb less calcium and phosphate. There's 3 studies published on this. There's 2 that looked at intermittent calcitriol dose versus daily calcitriol dose. They found no difference in terms of the biomarkers, PTH, calcium, phosphate. There was 1 study published in 2005 which found a reduction in phosphate. And again, that's because with intermittent dosing compared to daily dosing, that's again because you have less vitamin D around to absorb the phosphate that's in the GI tract. So what do I recommend when it comes to daily dosing versus intermittent dosing? Intermittent dosing may cause less absorption in phosphate and has no additional cost because what you're doing is giving that weekly dose 3 times a week instead of every day. So there's no additional costs or adverse effects that we're aware of. And so therefore I recommend continuing or in your units to dose it 3 times a week and at night. And so this is data that I didn't present, but giving your vitamin D analog at night, there's less calcium in the gut again, so therefore you're thought to cause less hypercalcemia, and that's been proven in 1 study. The very last study or not study, but the very last treatment that I'm going to talk about is the Calcimimetics. And the only one on the market is cinacalcet. So what cinacalcet does is that it binds to the parathyroid gland and changes the parathyroid gland to become more sensitive to the amount of calcium that's in the blood. And therefore, your gland thinks there's more calcium around and you'll produce less parathyroid hormone. This product is used, again, restricted for use in British Columbia, and I'll tell you why I agree with that. There is 1 RCT that looked at cinacalcet, and it was called Evolve, published in 2012. Adult HD patients with a median PTH of 76. What they did was, it was a prospective, multi-center randomized controlled trial, starting patients at about 30 milligrams a day of cinacalcet and escalating it up. The comparator was placebo, and the rest of the mineral bone disorder was treated at the discretion of the treating physician. And the outcome was that there was no difference in mortality, myocardial infarctions, hospitalization, unstable agenda, heart failure, or vascular events. So cinacalcet was not shown to reduce these endpoints, which we theoretically thought would do. But that wasn't the end from the creators of Evolve. What they did was start to publish every year after Evolve was published additional subgroup analysis from the original data set. So the year after, they published a paper that showed that cinacalcet reduced unremitting hyperparathyroidism. A year after that, they published some data that they claimed cinacalcet reduced fractures. I specifically stated there that cinacalcet does not reduce fractures. And the reason why I said that was I reported the unadjusted hazard ratio with intention to treat analysis. You'll see the hazard ratio crosses 1, so it's not significant. If you look at the adjusted analysis, you'll find that it was significant. And I'm very careful or very skeptical of any data that adjusts for baseline characteristics when it's RCT data. You just add more confounders. You shouldn't have to do that. The next year, they published some data that showed cinacalcet reduced FGF23 by 30%, and specifically in the group where FGF23 was reduced, there was a reduction in cardiovascular mortality. And again, the original trials showed no reduction in mortality, and again, this is adjusted data, and I remain skeptical of that. And these were not pre-specified endpoints. The last study that they published, or the latest study that they published, I'm sure there's going to be more, showed that patients who were prescribed cinacalcet had a reduced incidence of calciphylaxis. So on to my second last slide. In terms of the economics of cinacalcet, it's actually quite expensive. So 30 milligrams, which is starting dose, is $12 a tablet here in British Columbia. That works out to be about $4,000 a year at the starting dose, $16,000 at the highest dose. Unfortunately, there's no economic analysis that looked at this from the Canadian perspective, but if you're looking at data from the United States or Japan or the UK, it's generally accepted that if you're going to control PTH, vitamin D is more cost-effective, or parathyroidectomy is more effective, cost-effective. So in summary, mineral bone disorder isn't a condition that just affects bones, it's a systemic disease. And consequences include fractures, calciphylaxis, cardiovascular events, and mortality. Unfortunately, treatment does focus on correcting biochemical markers, which can be poor surrogates for hard endpoints such as mortality. And with these new products that have come to market, sevelamer, lanthanum, cinacalcet, the clinical advantages of using them really do not justify their cost in most circumstances. Any questions?